Hello friends, welcome to your own YouTube channel, Gynecologist Medical Lecture. I am Dr. Ruchika Garg, Associate Professor and a Gynecologist, and today we will be discussing about instrumental vaginal delivery. So there are two types of instrumental vaginal delivery, either forceps delivery or Ventose delivery. So what are the indications of forceps when forceps are required? So release forceps are the most commonly used forceps. So coming to the indications of forceps delivery, maternal indications or fetal indications. Maternal indications include when the mother is not able to either bear down or we want to cut short the second stage of labor, like in cases of previous anemia, mother is a case of anemia or mother is heart disease or a previous VBAC, vaginal cesarean section, or the patient's prolonged second stage, the duration of second stage is prolonged. It is more than 3 hours with epidural analgesia and priming, and with more than 2 hours without epidural analgesia and priming, and in multigravida it is more than 2 hours with epidural analgesia and more than 1 hour without epidural analgesia. So priming multi 3 2 2 1. So if the duration of second stage is prolonged, or if there are some fetal indications like fetal distress is there, meconium strain, liquor is there. So for any reason, if we want to cut short the second stage of labor, then we need to apply the forceps or Ventose we can apply. In cases of fetal distress, forceps is many times better because it delivers faster. Now coming to the what are the prerequisites before forceps application. Cervix should be fully dilated, membranes should be ruptured, head should be engaged, and there should be rotation. Either complete rotation should be there or only short of LOA or ROA, less than 45-degree rotation is there, and pelvis should be adequate, and there should be adequate uterine contractions. Cephalopelvic disproportion should have been ruled out, and membranes should be ruptured. These are the prerequisites, that is, and head should be at the perineum and it should be visible without separating the labia. Head is below +2 station ideally, and if it is visible at the perineum without separating the labia, it is at the +5 station. There are two types of outlet forceps application, either outlet forceps or low forceps, and previously we used to apply mid cavity forceps and high forceps, which are now absolute. And mid cavity forceps is, that is, the head is engaged, but it is between 0 and +2 station, but it is still in the cavity. And outlet forceps and low forceps. Outlet forceps means below +2 station but not up to +5 station, and outlet forceps is, it is at the perineum, it is just visible. Now coming to there are two, cephalic application and pelvic application can be applied, and the parts of the forceps, it is composed of shank, blades, lock, and there is a fenestration in between the blades for proper application of head, and there is a cephalic curve in which the head is accommodated, and there is a pelvic curve which follows the curve of Caras or the pelvis. And the right and left blades are decided according to the maternal side to which the blades are applied. So the patient is lying this side, so this is the right blade, this is the left blade, and now we have fulfilled the conditions. The head has rotated, it is visible at the perineum. We can apply the episiotomy either after the application of forceps or before the application of forceps, and we have taken proper consent from the patient, and now we will introduce the left blade first under the guidance of these 4 fingers, or if there is not more space, we can use only these 2 fingers, and we will apply the blade, and thumb is at this place, and then we will slip it, and we will ask the assistant to hold it and slightly depress it, and then we will introduce first this left blade is introduced, and then the right blade is introduced under the guidance of the left hand. This guidance is for protecting the perineal walls, the vaginal wall, otherwise they may tear. So on this thing, and then the thumb is here, and then we slip it, and if there is proper locking, that means the forceps had been properly applied. And now then we have to give the episiotomy, and we have to give traction. The traction should be given at the height of uterine contractions. We will ask our assistant to give proper perineal support, and then the direction of traction should be in this thing. In outlet forceps, just downwards and then upwards, and then head is borne by flexion, extension, and then we remove the blades, and first we remove the right blade first and then the left blade first. And if there is no proper locking of the blades, then we might need to insert, and there might be some faulty technique, or the pelvis might be contracted. This is in case of cephalic presentation, and after coming head of breech also we can apply forceps, but here the pelvic curve is absent. And in case of occipito-posterior position, face to pubis delivery also forceps can be applied. Here direction of traction is till the root of nose hinges under the symphysis pubis, followed by the occiput when the head is borne by the extension, and then we take out the blade, and then the procedure is the same. In low forceps, the direction of traction is somewhat horizontal till the head is at the perineum, and then downwards and then upwards. So what are the complications? Certain maternal and fetal complications can occur, like extension of episiotomy, deep episiotomy, perineal injuries, perineal tears, and extension into the sometimes bladder atony and bladder also. And in fetal, some brachial plexus injury and cephalhematoma can occur. Cephalhematoma might disappear in 7 to 10 days, and certain other nerve injuries can also occur in cases of forceps.